So a lot happening, a lot of new data to look at and to be generated, specific populations, but I think what we've learned is that we as clinicians and you out there as clinicians treat metastatic colorectal cancer correctly. And there's probably subsets where we want to look at surgical options. We might learn a little bit more about molecular profiling. Certainly we need to check the expanded RAS analysis to find some of these populations, including BRAF. But I think this has been a great discussion. I think we've reviewed a lot of information here. And in close, any final thoughts from our panelists? Tony.
I think that following CLGB 80405, and frankly following a couple of years of a lot of confusion about the right backbone and the right biologic, I think I have the utmost comfort now in maintaining the standard of care. This did confirm that all of us are doing the right thing, essentially.
Al?
I go back to, Alan showed a slide during the 80405 presentation, which brought me back to many years ago when I was a young GI oncologist, and believe me, there weren't many during that time.
I think you and I were two of the only ones.
And we saw the fluoropyrimidine alone arm, and most patients not living even a year, and this new era. And I think we should all celebrate years of clinical trials, and certainly in the United States and Canada, many physicians, community physicians, academic physicians, making all of this happen, and it is a celebration. Now we have other challenges, patient selection, and to make the next big leap, we're going to have to fully engage in clinical research and better understand the biology of colon cancer to do yet better for our patients. And after all, as many people have said, outside those we can resect with metastatic disease, we're still not curing the majority of our patients. So we still have a tremendous mission ahead of us, but I think all that has happened, exhibited at ASCO this year, also we should celebrate, and that should move us forward.
Excellent. Alan?
Well, obviously this was, it's special to have led a study that we sort of didn't change the standards of care, but we affirmed the standards of care, and I hope, and I think what Al said is right, that where we are now is so different from where we were 10 years ago. We still have a lot of work to do, and obviously what we can't be satisfied with the results that affect the average, give us a good average, but there's still some patients who aren't benefiting. So we have a lot of work to do, and I think we need to redouble our efforts to figure out the key components of how to treat patients and to get these patients on clinical trials. I think we absolutely, it was a fabulous collaborative effort to get us to this point from 80405, but we have to keep doing this, and we need to have the wherewithal and the means to do this. So I just agree with Al. This isn't a time to stop doing research in this disease.
Yes. Axel?
I think we're at a good point for patients. I mean, it's great to have these options. I think we're also at a point where we probably saw the last large, initially unselected, randomized phase 3 trial in metastatic colorectal cancer first line, at least the one supported by a cooperative group system, because our challenges are more complicated now. Our challenges are really diving into subgroups, molecularly targeted agents, integrating them into clinical trials first, developing platforms how to really distinguish between these subtypes of colon cancer, which we know there are. And I mean, it's not that the intergroup, for instance, is resting on the laurels of 80405. We're actively developing these concepts with the help, for instance, of Peter Dwyer and Hamilton as an intergroup effort to really pull off a new era of clinical trials where we start with patient selection up front and then try to see and try to validate the efficacy of certain agents that will come up in the near future. I think that's really moving from 80405 was the last benchmark trial. It sets a great benchmark, a great mark for us to move on beyond what we have seen so far.
I agree. I'm probably going to just wind up echoing, but I really do want to congratulate both the Alliance and SWOG for leading this trial and the other groups for actively contributing patients and intellectual property as well. It has informed us. It's going to newly inform us for years or decades to come. I am really happy that clinicians have these equally valid, both chemotherapeutic and biologic options in first and second and possibly third line treatment right now. And like the others, I think we are really on the edge of this explosion in biologically derived therapy. It's
Fantastic discussion. Fantastic future. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.